Hello everyone, this is Shadi Reis and this is SIF 22. With me is Dr. Taral Patel. He is an interventional cardiologist at Centennial Medical Center. Dr. Patel, you did a phenomenal talk yesterday about the PERT. And this is a new thing for interventional cardiologists. We didn't know about it. There was a PERT kind of initiative in the past, but since COVID came, it became more visible. Tell us about your journey and how is it important to you to start this program.
Well, thanks for inviting me to talk about this. It's definitely a topic that I'm passionate about. As I was telling you earlier in my talk, with most things, it starts with a single patient experience and a single encounter. Oftentimes, they're unfortunate encounters as these things happen in our field. And so several years ago, I was involved in a case where there was a sick pulmonary embolism patient, and we just didn't know where to turn. I'll leave the details out, but we just didn't know where to turn. And the patient expired as a young man with a family, and so that really kind of led me on the journey, to kind of find out how we could do better with this. And so I think, just reading about it, going to the PERT symposium one year, kind of opened my eyes to all the different treatment options, and so we. Myself along with some critical care colleagues who are young and very passionate and saw that in their training, became very interested, and we collaborated and kind of built our program. And then, as you alluded to, COVID has really been in so many ways very tragic, because so many people are dying of thromboembolic disease. It's, obviously, as you know, one of the leading causes of mortality in these patients. But from that standpoint, our learning curve just took off, with those patients who often show up with large saddle pulmonary emboli and are already compromised because of their COVID. And so we got tons of experience with catheter-based therapies.
Yeah. So now, with the cardiologists, we're very savvy with the catheters and catheter-based therapy. Now, the challenge I see from cardiologists is to build the program and awareness of the program. Right. So, what is the best way to approach this problem?
Yeah, I think like you said, raising awareness is the first thing. Just that there are, treatment options other than just anticoagulation. I think there's a general awareness in just the medical community and the ER community. So we did a lot of work with our ER physicians and hospitalists to really make them aware. And I think all it really takes for them is to see one really good encounter, one smooth procedure and one process where they could see a patient come in on 3 or 4 liters of oxygen, sitting there in bed reasonably comfortable. If they try to do anything like unzip their pants or walk to go to the bathroom, they're immediately dizzy, lightheaded, even pass out. And so they see that person get an intervention, whether it be thrombolysis, catheter-directed, or thrombectomy, as things are turning more towards, and they see, wow, the rapid turnaround, and they can get those patients out of the hospital faster. They can decrease their, length of stay, and I think that's it. They're sold. They're bought into the whole process. These days, we get calls from our critical care colleagues more that we turn down cases because we're not sure that the patient's going to benefit. But they call us about every single one. So I think just putting in the time investment to raise awareness, because everybody who admits these patients knows that they can turn on a dime. And I think everybody from an ER doc to a hospitalist has had the experience of somebody who looks stable. By the next day, they're in shock or they're coding or something bad's happening. And so I think for them to just be aware. So we did a lot of awareness. We kind of promoted our algorithm. We also made it easy for our colleagues to identify the person that they call. And I think that's the key. A lot of places they don't know, do I call vascular, do I call interventional radiology, or I call interventional cardiology? And we're such a large presence in hospitals. Interventional cardiology is just a logical place to turn. So I think, we kind of own the space, and we didn't really try to take it over. We really worked hard with our critical care colleagues to make sure, because they were obviously very involved in the treatment of these patients. And so it was a natural collaboration. There was no, turf wars at our institutions. We're fortunate in that. But just promoting the disease awareness and treatment awareness was the big thing.
Now, the options for catheter-based. Now, before there was the terms like clot buster with the echoes. Now we are sucking the clot. So we have too many options.
Yes.
Is there an algorithm or there's a document where physician can refer to what device they use in what situation?
Right. Yeah. No, that's a great question. I think that's where we need data. We need a lot more data, and our institution is actually involved. We're going to be enrolling patients in the randomized trial of catheter-directed thrombolysis with ECOS catheter versus thrombectomy with Inari FlowTriever, which is the most common device. There's a couple of others, as you know. And I think that for kind of large saddle central pulmonary emboli, thrombectomy seems to be the go-to, and a lot of institutions that have been doing thrombolysis have kind of moved over towards thrombectomy because you see the result immediately. You get the clot out. The patient feels better on the table.
Yeah.
It's fairly dramatic. Whereas ECOS works. It's definitely very impressive technology, but I think if you have any trouble aging the clot, if it's more than 2 to 3 weeks old, you're going to struggle a little bit to dissolve that, especially with the flow dynamics in the pulmonary circulation. Oftentimes, you're just not going to get good penetration. Whereas I think with more distal clots that are kind of broken up in the subsegmental and more distal circulation, it probably makes more sense to kind of drip in TPA into each pulmonary artery over time.
But that's beside the patient need for ICU bed, right? For ECOS.
Unfortunately, yeah. Unless you have a way to have those patients in a step-down unit where nursing can keep track of those catheters. ICU is where most of the ECOS patients go, whereas with after catheter-directed thrombolysis, they can literally just go to the step-down floor.
Absolutely.
Any nurse that's comfortable with managing groins can manage a post-thrombectomy patient. So I think for a lot of reasons, thrombectomy is becoming.
What's the protocol after doing thrombectomy? Do you start anticoagulation IV or you give them oral therapy right away?
Yeah, that's a good question. I think another question we need to learn more about. We've done both. I think we're concerned about potential, larger patients, increased bleeding risk. We will often wait a couple of hours and start anticoagulation IV. So if there's a groin issue, we can turn it off. These days with ultrasound access and becoming comfortable with large bore access, those things are becoming less and less common. So a lot of times we will just start oral anticoagulation unless there's some other reason not to.
And in terms of the sheath size, as you said, depends on the device, from 12 all the way to 23, 25 dry seal. What's your closure?
Yeah, so closure is, we currently are using oftentimes afterwards a single per close and then a per string. And it's a really nice technique. It's similar to what they use in mitral clips. The Inari and a couple of other companies have actually come up with a really, really simple device where you just pull the sutures through and cinch it down, and it's like magic. So it's really, really simple. You don't even have to tie a knot anymore. It's really nice.
Nice. And then nurses on the floor can basically open it up. And
exactly. The nurses can literally just clip it and they're done.
Have you looked into your data to see your length of stay, discharge?
Yeah, so we have not looked at it in a systematic fashion. We have post-PERT data, so we've got all that data. Unfortunately, we weren't collecting data before we implemented the PERT program, so we don't know, but the length of stay for our thrombectomy patients is probably, I actually have that data in the talk, but it's probably about 2 days or less on average. So,
impressive,
these patients, it depends on the time of day, as you know. I mean, if the procedure's done kind of early in the day or early afternoon, by the next day, oftentimes the patients are like, can I get out of here now?
Yeah.
So the length of stay is pretty low.
It's like a really exciting time how we are changing and shifting gear of treating PE now.
Yeah.
And it's becoming the new STEMI for cardiologists.
Exactly. I think that's a great point though. So I think, we have to try and wrap our hands around how committed we are to this. We're already taking STEMI calls. Some people are taking acute limb call.
Yeah.
And so do you really want PE to go on top of that when our teams are tired, cardiologists are tired? So I will say that oftentimes, if it's 8 or 9 o'clock at night and the patient's stable, I'm going to just put them on heparin and wait till the morning. I have a low threshold to come in, because all of us who do this have had at least one experience, and I have, where a patient, decompensated overnight, and then you're coming in like a STEMI when the patient's really hot and compromised. So I think, again, we need more data and more studies in that category. Yeah.
Well, Dr. Patel, thanks so much for your time. This is very, very insightful about your journey and how much you contribute about the PERT program.
Thank you.
Please watch this video and others on SIF YouTube channel. This is Shadi Reyes from SIF 2022. Dr. Patel, thanks again.
Thank you. Thanks, Shadi.
All right.